Ladies and gentlemen, welcome to the Immunizations video series conference call. Your host, Michelle Dewey, will now begin.
Good afternoon, everyone, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. Lake Superior Quality Innovation Network is comprised of 3 organizations, MPRO in Michigan, MedStar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior QIN YouTube page within the next week. I would like to introduce you to today's speakers. First, we will have Marianne Langlois, Site Director of Henry Ford Cottage Hospital and Grosse Pointe Pearson, Hamtramck, and St. Clair Shore sites. She facilitated the adult vaccination project with Sue Kraft, who will also be on the call, and she is a nurse and director of the Care Coordination Initiative, also at Henry Ford. And they have rolled out this new process to all their sites and are excited to share this with you. Also joining us today is Laurel, a longtime nurse with Henry Ford Home Health Care. She has been the high-tech coordinator and a nurse for 37 years and has been with Henry Ford Home Health Care for 24 years. She is a teacher and preceptor and works on policy creation and revisions for infusion, transplant, and LVAD patients. So we hope you'll enjoy. The goal of today's webinar is to provide clarification for any points brought up in the videos and/or answer any questions you might have had. We'll go through a brief overview of the vaccines, and we'll specifically be talking about influenza, pneumonia, and shingles, and then we'll also do a little segment on standing orders. So adult vaccination is a high priority, but not one that gets as much coverage as other vaccinations, and specifically we're most interested in influenza and pneumonia, so shingles rates could be increased as well. With adult populations, it's our older adults over 65 that we're most concerned about, as they have the weakened immune systems compared to other adults. And we're also interested in getting everyone vaccinated for herd immunity to keep those who can't be vaccinated protected as well. And then just general protection for yourself, your family, and the community around you. Okay, so a brief overview of each of the vaccines, starting with influenza. The influenza vaccine, or more commonly known as the flu shot, is protected for the duration of the flu season. It's recommended for everyone 6 months and older, and highly recommended for those 65 and older, as well as those who are immunocompromised. It's available at physician offices, also local pharmacies, and health departments. The pneumonia vaccines are also important.
And my name is Michelle Dewey. I'm going to give a brief overview of the pneumonia vaccines. There are 2 types of pneumonia vaccines, the PCV13, which is known as Prevnar, and the PPSV23, which is the pneumonia vax. The pneumonia vaccine protects against pneumonia, and it is recommended for adults 65 and older, as well as the immunocompromised. It is also recommended that patients with chronic conditions such as diabetes and heart disease receive the pneumonia vaccine. These are both available at your doctor's offices, local health departments, and at pharmacies. The PCV13 is given first to the adults 65 and older, and then 1 year later, the PPSV23 should be administered. And it is important that the vaccines are given at least 11 months apart in order to receive reimbursement from Medicare. And again, both of the pneumonia vaccines are recommended for adults 65 and older, and for those with chronic conditions, and also to those who smoke cigarettes. The rates in Michigan tend to be pretty well received, and we have found that most people have had an experience with pneumonia. Either a family member has had pneumonia, so a lot of adults are getting the pneumonia vaccine. However, according to our rates from MICR, since MICR is not recommended for, or is not required to report the vaccines to MICR, the rates that we've seen are a little bit low. It says that 29.9% have received the PPSV23, and then 21.5% have received the PCV13. But we have found that through claims that those percentages are a lot higher. Okay. So, and next is the shingles vaccine. The shingles vaccine protects against shingles and post-herpetic neuralgia, which is severe pain. And it is recommended for those 60 and older, as well as the immunocompromised. And these are available at doctor's offices and local pharmacies.
Okay. And standing orders is something that has been gaining more attention recently. Standing orders make it really easy to get vaccines. If you have a doctor's order, and because we're in Michigan, it needs to be a Michigan licensed doctor, this standing order authorizes nurses, pharmacists, and or other healthcare personnel to administer vaccines. So it doesn't take time away from the patient's visit in the office, and it allows them to get the vaccines that they need. These vaccines can be received at the doctor's offices, either just by someone not the doctor, other clinics, hospitals, pharmacies, health departments, long-term healthcare facilities. Anywhere that you have a licensed vaccine provider, you can have standing orders implemented. Okay, and then we also wanted to mention the vaccine replacement program. It's recently expanded, and it's available for adults who may not have insurance, or their insurance does not cover any part of vaccine costs. And it's recently expanded to include both pneumonia vaccines, so the PCV13 and the PPSV23, as well as the shingles vaccines are both available. And the vaccine replacement program vaccines can be found at local health departments, federally qualified health centers, migrant health centers, and tribal health centers. So just something to keep in mind. Okay, and now we're going to turn it over to Sue Kraft and Marianne Langlois from Henry Ford Health System to speak about their shingles vaccination program.
Okay, thank you very much. This is Sue Kraft, and I'm just going to start and give some background information on kind of what we did here at Henry Ford, and then Marianne will give you more detailed information about how the clinic process actually works. So, why did we focus on shingles vaccine? So we started way back in 2013, and we're looking at our immunization rates, and we knew that our shingles rate was extremely low. We also knew that we had some significant issues with patient satisfaction because we had this incredibly convoluted process to get patients vaccinated. So we didn't carry any the shingles vaccine in the clinics. They were only stocked in our outpatient pharmacies. Not every clinic site actually had an outpatient pharmacy. And so the areas in the clinics that did have that, they would send patients over to the pharmacy who would verify their coverage under Medicare Part D. And then there was a additional process of getting the vaccine actually transferred from the pharmacy back to the clinic. We had to send the patients back and forth. They would get their vaccine. The pharmacy would do the billing. And then the pharmacy actually would reimburse back the clinics. And so it was not a smooth process. A lot of issues were identified. Our providers didn't understand the insurance coverage at all, and it is really quite a bit confusing when you actually look at Medicare Part D and all other coverage. And so we knew that we had issues, and we had to figure it out. So we got together a very large multidisciplinary team that included our clinic staff, the outpatient pharmacy, billing, our revenue cycle group. We had our internal EPIC team as well as the EPIC team from Wisconsin. We had our compliance representatives, and we had our colleagues from Merck that were kind of helping us on how to do all this. And so one of the things as we looked at how we needed to implement these changes, the biggest issue that we knew was the billing piece, and that was something that we really needed to figure out how we were going to fix that part first before we could really look at any process changes or anything else. And you guys can advance the slide. Thanks. So as we started working down that path of how do we do this billing, we became aware of Transact RX and that we could actually use a third party to do that billing for us through the Medicare Part D, and we could take that process that went back and forth between the clinic sites and the pharmacy and move it all to the clinics. And so we, as we worked through that part and how we would do the billing and make sure that that documentation occurred in Epic, make sure that we were identifying the correct patient population, we moved all of vaccines from the pharmacy to the clinic, and then we started to roll out our new process. And so we actually integrated the use of Transact RX into the daily clinic workflow in July of 2014. And so we had a lot of iterations on how that workflow was actually going to happen. We had different clinics trying different ways to make it as smooth as possible, and we finally were able to kind of identify a best practice, which we ended up rolling out across all of our clinic sites. And so we used the medical assistants initially, and then really wanted them to kind of own that process, but we really learned as we went along the way that we needed to include the front desk staff as well, especially in the billing piece. So I'm going to turn it over to Mary Ann now to talk a little bit more in detail about what they did at the clinics.
Thank you, Sue. This is Mary Ann Langlois. So I was interested in this process when Sue approached me for the point that my doctors were always coming up to me and I had patient complaints that they were sent to the health department, they ended up paying full price. Patients that had regular insurance, not Part D, were being sent elsewhere, and we really could have taken care of them, but we didn't have the vaccines in our clinic. So there was definitely buy-in on our part to help assure our patients were all receiving the vaccinations they needed to receive. So we had 23 sites. So I rolled us out to 23 sites. So Laurel Lucasevich is our Merck representative, and she was extremely helpful. We took an Epic person. They assigned us through our EMRs. We had one person that was going to be assigned to this project to really roll it out. Many site visits to train the staff. Initially, we let each site kind of come up with what was the best flavor for them. Sometimes it was the MAs were really strong and they wanted to do the entire process. The front desk was very good and they really felt that they could take it on. But in the end, we finally, between myself and the other directors over the sites, met with our boss and who said, we got to have one process here. So the process flow I'm going to be showing you is what we came up with. Initially, we started, and then our other hospitals, Macomb and Wyandotte, they also wanted to do this. So there's 14 sites there, and so they've been implementing the process too. So we went out and we trained, and we have a little flow sheet here. If we can change the slide. And actually, okay, this slide shows you Transact RX, just so that you can see what it looks like. Once you enroll, you do have to enroll into Transact RX. It doesn't cost you anything. This process here shows you that this is what the CSR, what we call clinic service representatives at our front desk. This is what they have to enter. You mainly just have to have the patient's name, the date of birth, the last 4 Social Security numbers, and then also what vaccination the doctor who is going to be, that the patient is under, and then you just hit enter, and then it'll show you whether they're accepted or not. If it's rejected, they don't have Part D, or it could be that Transact RX doesn't have them enrolled yet. So we've actually let Transact RX along the way, let them know, okay, here's an insurance we're seeing on a regular basis, and it keeps rejecting. Can you approach them? So they go out, they solicit that insurance, and they'll enroll them, knowing that insurance knows that we are, we want them. So we actually help Transact RX to get more insurances under their system. So that's the system that we're talking about here. If you can show the next slide then. So this is the clinic workflow, so what we came up with. So the night before, and sometime during the day before, you've got the doctor schedules filled mostly, unless there are same days. But the other patients you can be proactive with. So we have our front desk looking at patients that are age 65 and older, and they are looking up those patients to see in what we call health maintenance in Epic. And in health maintenance, it shows if the patient actually needs these vaccines, because some of them could already have received them. So they come up with that patient list. And then they take that list and they go into that system I just showed you, and they enter that information for each one of these patients. So if they do find somebody that it says accepted, they have to send the account and they print the claim. The reason being, this form that they print out has to be signed by that patient the day of. It's a pharmacy requirement. Patient is basically saying that yes, they do want to receive this vaccination. So that's critical that we had to have that form, and we have to also make sure that it's uploaded into our EMR. So that is something that the MA goes over with the patient, along with the doctor. Patient wants to receive this vaccination. They would then complete that form, give them the vaccination, and then that form is signed by the patient, and the MA gives that back to the front desk, who then would scan the form and also submit the bill. So that was critical that we had to make sure that we were submitting them after the fact. And then if it's rejected, the MA is made aware that it was rejected. We give the patient a step-by-step guide to verify their coverage. So it may have been rejected in that system because that insurance was not one that Transact RX was enrolled with. So the patient could go out, still receive the vaccine, pay it up front, and then go to their insurance and get reimbursed also. So that was our process. If the patient decides they don't want it, and we did have a lot of patients, especially at the beginning of the year, they have high deductibles, that we had a couple that came in, and the husband said, why is mine $200 and my wife is only $35? Well, she had met some of her deductible already. So that was educating, especially clinical staff, how these deductibles work with insurance. So this was new for a lot of our staff. But if they decide that they do not want that vaccination, those forms still had to go back to the front desk, because then the front desk person would have to cancel it out in the system. If we can go to the next slide. What we did, the reason why this here, the daily review of pending claims, what we were discovering as I was going back and auditing is that these accounts were not being reconciled at the end of the day. And when they're not reconciled, I discovered that after 2 days, if they're not reconciled, they automatically cancel them out. So if the medical assistant did not give that form to the front desk, we never will submit that bill. We would have not even known because it's already canceled. There was no follow-up with that. So I have an assistant that goes through, here's all of our sites on here, and she basically just looks for two things in Transact RX. She just looks at the day that, let's say it was from yesterday. So you go into yesterday's and you look to see if those, by 9 a.m., all those accounts were reconciled. There should be nobody red. If it's in the red, it means it's still pending. So they either have to be canceled or submitted. Well, then she goes to today's date, and she looks to see by 9 a.m. if anyone's been entered. So we wanted to make sure that the front desk was actually entering patients into this system so that every one of these, as you can see, there's quite a few sites. I wanted to make sure that every site was actively doing this process. So that was my check and balance by looking to see if they're being entered. And then the reconciled one was to make sure that at the end of the day, they had a CSR that was going through and taking all those sheets and basically reconciling it, either canceling it or hitting submit so that we could get the bill out the door. Now, if we go to the next slide here, and before I actually do that, well, you can go to the next slide, but something that we put in Epic, and in our Epic system, when the MA is getting ready to give the vaccination, they have to answer these questions. Of course, it's have you ever, this is for zoster, have you ever had a serious reaction to eggs, yes or no? Been diagnosed with cancer, leukemia, AIDS, or an immune system problem, yes or no? Was patient given a current VIS, yes or no. And then, is this a Medicare Part D Transact Rx billed vaccine? If they answer yes, then when they give that vaccination, we set up a bucket where instead of it going to the patient's insurance, it goes to this dummy insurance and goes into this bucket, which does not get billed out the door. That was our big challenge. How are we going to make sure that these actually don't go out the door because it's being billed through this Transact Rx? So that was the solution we came up with, and it does work. And if they say no, then it goes into the patient's regular insurance, their health insurance. So that was how we were able to do that. And also, just so you know, the impact that initially in the beginning of January of 2013, these are patients with primary care visits and were eligible for zoster. We were percentage of active patients who received that vaccine when they came in was around 9%. And in August, after we implemented it for a couple of months, we actually went up to 30%. So it did make a difference. It was worth all of the work that we did to implement this, in other words. So what are some of our lessons learned? Making sure that we understand who all the players are. We had a lot of nurse managers that ran their sites, and they each had their own way of doing the process. So this was kind of a first for all of our sites to start standardizing. That's a key process that we're trying to implement at all of our sites, so patients have the same experience no matter what site they go to. So this was our first try at that, and we had lots of learning opportunities. Communicating with everyone, making sure everyone understands how it works. Laurel, who's our rep for this vaccination, was going to sites whenever. She was so helpful for me because whenever any of our staff had questions, this patient's still not sure why it's not working, I would give her a call, and then she would just stop by and try and answer their questions. Staff wasn't sure, doctors were not sure how they should bill it, when they should bill it, and so forth. So I can't thank her enough. And also, each Part D plan is unique. Some of them, we're just learning after doing this for a couple of years that there's a 90-day window that you can bill these out. If you don't bill it the day of, and some of those insurances only allow 30 days for you to get that bill out. So it's a different model when you think about the health insurance we deal with in the clinic, and now you're starting to deal with the pharmacy, which we really don't. So we're learning a little bit how that insurance line works. Physicians and support staff make sure that they have the education around vaccination and reimbursement. That was multiple times. Laura had to go, and at sites, I think one site she went to about a dozen times because they kept, now how does that work? Not really sure how the insurance works. And then what we really, really pushed as we went around and trained Transact Rx, it's extra work. It is extra work. So the best opportunity is between 60 and before 65 to vaccinate these patients with Zoster. And that was really key to get the docs to really, and the Tdap. So then that way it's under their regular insurance, they're not dealing with that deductible, and it's covered nowadays with the Affordable Care Act. So that really helped to push that number up. It wasn't so much the Transact Rx, but getting out there and training them, and making sure we try and get our docs to try and provide it between that window of 60 and 65, and then giving another option for our patients that have already reached 65 and older, that we have some way to give them that vaccination too. That's how we tried to sell it. That, we know it's extra work, but if we start really working on that age window where we don't have to use Transact Rx, and then use this however long we have to until we catch everybody up, that was a way to try and sell it. And that was our process.
Great. Thank you so much for sharing. That was definitely beneficial, and I think a lot of us can use that. If anyone does have any questions at this point, we can put them in the chat box, and we'll do all our questions at the end. And for now, we're going to turn it over to Laura Lenahan, also from Henry Ford, but Home Healthcare, and she's going to speak about influenza.
Okay, well, first of all, hello, and I want to thank our Perna for allowing me to present this. I really appreciate the opportunity. I'm going to share how Henry Ford Home Healthcare has constructed a flu vaccine program, the beginnings of a flu vaccine program, for our home health care and our homebound patients. Why we're doing it, how we're doing it, and a few lessons learned so far. This is a process that's pretty much just becoming started. Go ahead and turn it. The Center for Medicare and Medicaid Services has a star rating that is published on a quarterly basis. And in 2014, our home health care star rating was a 1.5 out of 4 in the area of flu vaccination. So, to be honest, the impetus for creating this vaccine program was to improve our CMS Star Rating. That rating is a comparison for consumers of home health agencies, and it's published on the Home Health Compare website. There's 29 quality measures, and 9 of them are selected. They're summarized. They're listed on the Home Health Compare website. And of those 9, then the quality item number 3, which is on the slide there, rates the home health agency on the assessment and the provision of the flu vaccination. So the intention is to determine if the flu vaccine has already been received during the current flu season, and if it has, which healthcare provider provided it, or if it has not been received, why not? Did they decline? Is it contraindicated? That data is taken by CMS from the OASIS assessment, which is our outcome and assessment information set that is done on all of our Medicare, Medicaid patients and some other insurances. And it's taken at the conclusion of a service episode. It's completed by our clinicians. Now, the flu quality measure is a process measure. It's not an outcome measure, and it's listed under, I guess you could say, under quality of patient care, which is under preventing harm as in decreasing the risk of influenza, complications from influenza illness, and readmissions. So in 2014, our star rating was only 1.5 out of 4. In 2015, it was 3 stars, but 3 stars is only average, and we knew we could do better than that. Go ahead. And so, although it was understood that Henry Health System screens patients for the need of vaccination, flu vaccination, at various contact points, our home care OASIS data showed that many home care patients at the conclusion of our services during flu season still had not been vaccinated. It's 2 things. Either the nurses are not accurately assessing that item, or the patient, in fact, has not received the flu vaccine. In either case, it was determined that home health care should be providing these flu vaccine to our patients who've not had them yet. And so in September of last year, I was approached to create that program. Lessons learned right off the bat was I wrongly initially assumed that I knew or could just simply go and get styrofoam coolers from the pharmacies and get these little card cold chain thermometers and use those. And I brought all of these pharmacy-grade styrofoam coolers back to my office, all 30 of them, and rapidly then understood that the CDC requires something completely different and had to return them all. So right off the bat, it started to become a bit of a learning curve. The CDC does list basic requirements, and those are in the Handbook for Vaccination Transport, Storage, and Handling. And the very basic ones are listed on the screen, which I have to make bigger here, which is Reduced potency from heat, cold, and light. If there is not proper temperature control of the vaccine, then it will reduce the potency of the vaccine. I'm going to skip down to the third bullet. I actually called Santa Fe Pasteur twice to make sure that I was understanding correctly that a vaccine, like a pre-drawn syringe, for an example, or a multi-dose vial, at the point that it has reached room temperature for 30 minutes, it is already losing potency. So I asked them to send me a letter to that effect, which they did, so that I can have a bit of a paper trail for, putting into our policies how we're doing this. Going back up to the top, the cold chain temperature supply chain for equipment and procedures, that begins at vaccine procurement. So in other words, when I go over to Henry Ford Hospital main campus, the basement pharmacy, and pick up the vaccines, my control over the temperature of those vaccines begins there. Whether I take them back to my office near the hospital or take them to a branch office further in the community, I have to have control and prove that those vaccines did not exceed the temperature allowances. Now, for home health care, the fourth bullet down, the challenge is that, and we'll get into this in a minute or two, a few slides from now, is an unknown, an undetermined amount of time that a vaccine is going to remain in some person's car, in between other patient visits, in between vaccination visits. Just the fact that it's a car and traffic and all kinds of reasons, the cooler that the vaccine is in has to retain that temperature control in an uncontrolled environment that the cooler is sitting in. Now, when I started the pilot last year, I was the only one who gave those flu vaccinations, and I was giving them during non-billable visits. Run in, give the patient the vaccine, wait to make sure they're not having any kind of adverse reaction, leave. So I had control over my visits. This year, it's different. We'll talk about that in a few minutes. But there was a bit more control when it was a few patients by one nurse doing this, and I could largely control my timing. Also the CDC basic requirements is that there's written protocols for routine and emergency vaccine storage that has to be annually updated. There has to be a dedicated refrigerator to maintain the needed temperatures of between 35.0 and 46.9 degrees Fahrenheit. Even the refrigerators themselves are very specifically addressed in that handbook. Yes to this type, no to that type. Go ahead and turn it. Okay, so as far as purchases goes then, I have a couple slides just because I didn't know if there was another home care agency that might be interested in doing this and them wondering what purchases they would need. But the CDC does recommend a device with continuous monitoring 24/7 and recording capabilities with a certificate of calibration. What they do not recommend are these little card cold chain monitors. They're small, like a deck of, like a card from a deck of cards, or even smaller than that just simply turn colors if there's been an excursion of temperature. There's no way to know when that excursion took place, how many minutes or hours ago. So they recommend a continuous monitoring. So what I purchased then was 8 digital data monitors. The picture is there. And that the control solution is a manufacturer that I purchased them from. One is in each of our refrigerators. There's a total of 4 refrigerators, 3 for each branch office, 1 for our main office downtown. And then one that is called a courier. It's the same exact data monitor that goes into the courier, the transport cooler, when we take that vaccine out of the refrigerator. So the refrigerator is monitored continuously. You can set it for having a readout of temperature every 5 minutes. I have ours set at every 30 minutes, and then there's one, the exact same one that is in the courier. The little glycol that's next to it, that is what the probe goes into, and the coldness of that glycol is what causes that digital readout on the data monitor. The product features are listed there, and those are listed on the website of that product manufacturer. Go ahead. I got to keep up with this too. The second purchase done was the coolers, and again, I had brought back 30 styrofoam coolers, and then I had to return all of them. Luckily, they were accepted as returns. But what the CDC requires is a hard-sided insulated cooler with at least 2-inch thick walls and 2 inches of coolant packs. There has to be a barrier device in addition to those between the vaccine and those coolant packs. I use a plastic Tupperware type container. And then the courier itself, even though it's temperature controlled, cannot be used for long-term storage. If you have vaccine in it longer than 8 hours, then there has to be every 1 hour temperature monitoring and logging. So that's the courier. It actually has 2 freezer belts. You can see in the first picture, one, that's a freezer belt. It takes 12 hours to freeze. The second one is a refrigerator belt. It absorbs that excessive coldness from the freezer belt so that vaccines won't have excessively cold temperatures. And then the freezer belt also keeps that refrigerator belt cold enough. And then the third picture is just a clothes. They come in various sizes. They're, what did I say, $285 each, or $35, whatever it says there, each. So we had to get 4 of those. The rolling carts to put the courier in because there's other supplies that are needed, syringes and needles as needed. Epinephrine ampules in case there was an anaphylactic reaction with a filter needle in the syringes, sharps container, gloves, alcohol pads, etc. Go ahead. Now, that was the expenditures. And as far as staff, then vaccine coordinator, which I guess that's what I am, there needs to be a primary coordinator and also a backup coordinator. So if I'm gone for an extended amount of time, then someone else can have that oversight. This is what the CDC requirements are stated. Vaccine procurement and delivery to the branches. Office staff, again, there needs to be a primary office person, as in clerical, and a backup person for visit assignments. In other words, our nurses going out, they're LPNs, by the way, to go out and provide this vaccination. These visits may or may not be associated with a more extended, larger picture skilled visit, so there have to be assignments of those visits. The office staff also are responsible for the storage of all of the equipment. The epinephrine, for an example, has to be at room temperature, cannot be in the refrigerator. Various logging and all supplies. Nurses for administrations, again, we have designated LPNs that I'm currently this is the first year. Last year was just me. This year is the very, very beginning of training, and there's one office I haven't met until next week, and my training, the LPN's there. And then the EPIC and MICR entry now, I am not involved in that. There's a designated person. Henry Ford Home Healthcare is read-only into EPIC, so I'm not the person who's going to be entering that, and to be honest, I'm not 100% sure of that process, but the designated person who does that is going to have that responsibility. Okay. Nurse training and education, the LPN training, involves vaccine information, the big picture about the vaccine itself. How is it made, but what is it comprised of, trivalent versus quadrivalent, et cetera. Influenza, the illness of, common myths in case they're asked by a patient and some wrong information is stated. The nurse has enough understanding of influenza that they can teach. And then the administration of visits. This is home care, so there's all kinds of logistics that are involved with assigning and making patient visits into the community. Scheduling and obtaining and returning supplies. The big buy-in for our home care staff is they have to return the courier at the end of the day. Absolutely no questions, because that freezer sleeve takes 12 hours to refreeze. They have to be trained in the use of just largely the refrigerator storage. It's the office staff that is responsible for that, but the nurses need to understand it also. Data monitor, they have to be able to use that data monitor, understand the lights, what they mean, what they do about temperature excursions. They need to understand how to use that courier and conditioning the courier before they retrieve vaccine out of the refrigerator. 15, 20 minutes to get that courier down to a certain temperature before they leave the office. They need to understand that the vaccine information statement is a federal requirement for providing to the patient prior to administration. And our consent form, which isn't technically a consent form, the patient has to sign to state in part that they did receive and read the VIS. So there is a patient signature. And then nurses need to be trained in anaphylactic response recognition and their response and communications, etc. after the fact. Go ahead. Clerical training of the computer software. These data monitors have a computer software that shows up temperatures in a graph form and in listing form. They need to understand how to turn these data monitors on and off, create files for every single date that the courier data monitor is taken from the office and used. They have to understand the refrigerator storage. They are the ones who are responsible for any problems with the refrigerator, including freezers defrosting, which we've already experienced. Making sure that the refrigerator signs are on, no food in the refrigerator, all of that stuff. Receiving requests for patient vaccination. There's this whole process whereby we go through our e-home health care. It's requested through them. They send it over to the team leaders, and then it gets assigned. Logging of requests. There's in a little bit there is a form that is a combination request form, return of equipment form, temperature of the data monitor when it got back to the office form and billing form, and then also communication of vaccine supply needs that goes to me. That's our clerical training in a nutshell. Go ahead. Determine a visit type and date. I'm not really going to go over this. If there was another home care agency on the phone, if you're interested about the large picture of non-billable visits versus billable visits and all the logistics that go into trying to figure that one out, I'd be happy to talk with anybody, but we'll go past that now. The logs that I'm using are, absolutely homegrown, and they're already causing some problems. They will be revised in March of next year. All of the persons, clerical and LPNs at each of the three branches, we will all meet together and have a powwow of what's gone right, what's gone wrong, including things even like the logs. How easy were they? Did they capture the information that we needed? There's a vaccine transport from the pharmacy to the branch. That's one I would use when I pick up the vaccine. And then there's a log that is used for requesting, billing, inventory, and equipment return that is made out by the team leaders. Temperature control refrigerator, the CDC says even though you have a data monitor, someone has to look with their eyeballs twice a day and actually write down on a piece of paper twice a day what the temperature is. That's me truly, and boy, that's turning out to be the hardest part of everything, is me getting over to that refrigerator twice a day. Vaccine only, this is just what we'll put on our refrigerators. Go ahead. And then in case of anaphylactic response, I have the emergency supplies, the filter needle and the appropriate size syringe and the epinephrine and this laminated half-sheet card. It's in bright, it doesn't look like it here, but bright neon green on both sides of the paper, so that, you know, as a nurse may be wondering, is what I'm seeing really an anaphylactic reaction? What should I do? Because, you know, in that kind of a situation, you get nervous and all of that. So that's in there. 1 in 1 million persons is who have anaphylactic reactions. It's very unlikely, but you never know. And next. And that's it. So if there is a home care agency that wants to know more about the, specific detail, feel free to contact me.
Thank you, Laura. It was super informative as well. And that actually concludes what we have for you today. So if anyone has any questions, now would be the time to take them. So we can open up the line, and when you do state your question, be sure to tell us your name and the organization that you're from. Thanks.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. And let's wait a few seconds while our callers come into the queue. Again, ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone.
Okay, while everyone's thinking, I actually have one for Marianne and Sue from Henry Ford. How does the Transact RX work with MICR, or does it not work with MICR?
How does it work with MICR? With MICR Transact RX, it's not, we actually feed into Epic, and then Epic will feeds it into MICR.
This is Sue. We actually have been a pilot site for the state on a bidirectional feed with MICR, so that vaccines that are administered elsewhere in the state for our patient population flow into Epic. I know there's been some glitches along the way, but I don't think there's not a connection between Transact RX and MICR. It's more Epic and MICR.
So when we're entering that question that said yes or no, if this is a Transact RX, it's creating that dummy charge code, so then that way it's still, that whole process still works. It's just not getting billed out.
Okay, thank you. That's good to know.
I've got a question also.
You're good.
Okay. I have a question also. Marianne, as far as the Transact, this is Laura, as far as the Transact goes, what insurances can be used for that method?
It's the patient's Part D insurance, and I have a list that's probably about 8 pages long of insurances that they have.
Okay. For various insurances. Okay.
Flu and pneumococcal are under B. Yes, the flu and pneumococcal are under B, not the D as in dog.
Oh, okay. Is under D. All right. Thank you.
Transact RX is only to bill the Medicare Part D plan.
Again, ladies and gentlemen, if you have a question, please press the number 1 key on your touch-tone telephone.
And then to all our participants, if you could please take a moment and fill out the evaluation questions that have popped up on your screen and just let us know how we did today, that would be great. And while you're doing that, I have a question for Laura. How did patients react to this when you did that? Like, were they kind of surprised or?
Yeah, so I mean, I only did, we're talking minuscule amounts, right?
Right.
Last year I did a whopping 29 patients. Every single one of them was happy as heck. And plus we're offering it to their spouses, regardless of whether they're home care patients. We're also doing this if we're roster billing Medicare only right now, if we're not even worrying about the insurances, we're doing this as a freebie.
Okay.
So to the spouses, so people are very, very pleased with it. That we've got some patients who are very homebound, so having that touch into the system can be few and far between.
Operator, are there any questions?
No, ma'am. There are no callers in the queue for questions.
Okay, well, thank you for joining us today for the Immunizations video follow-up question and answer session. As a reminder, the slides will be available on our Lake Superior Quinn YouTube page within the next week. And be sure to join us for our future events. Our next one is a standing orders workshop that we will be hosting here at MPRO on November 15th. And the details for that are to follow, but we hope to see you there. Thank you.
Thank you, ladies and gentlemen, for joining today's call. You all may disconnect at this time. Thank you.